So I think we are live. Assalamu alaikum wa rahmatullahi wa barakatuh. It gives me a great pleasure to be moderating the debate of the SSBMT for tonight, which is entitled, "Is Warfarin dead as a treatment for new venous thromboembolism, yes or no?" And we are really glad to be joined by two speakers from the United States tonight who will be debating this topic. I'll start by the first one. So Dr. Alvin Schmaier is the Robert W. Keller-Mayer Professor of Hematology and Oncology and Chief of Hematology and Oncology at Case Western Reserve University and University Hospitals Case Medical Center, Cleveland, Ohio. He's formerly a professor at Temple University and the University of Michigan. At both institutions, he was director of the Coagulation Laboratory, and at University of Michigan, he was course director of the hematology sequence from 1999 to 2005. He was an associate editor of Thrombosis and Hemostasis and serves as an advisor to the Journal of Thrombosis and Hemostasis. He's the president of Thromgin Incorporation. His research area is in the field of hemostasis, thrombosis, and vascular biology. And he will be actually making the case that, yes, warfarin is dead as a treatment for new venous thromboembolism. So I leave the talk to you, Dr. Schmaier, and the podium is for you.
Thank you very much. Can we move to the next slide? Okay, excellent. Well, thank you for the opportunity to be here. This is quite an interesting experience. And obviously, you've given me the opportunity to talk about what I love to talk about is anticoagulants. Now, today we have choices. And is it warfarin or is it a DOAC? And I'm going to say for most of our patients, we can choose a DOAC. These are my disclosures. Now, you know, the area of the pharmacology of anticoagulants and antiplatelet agents is really a growing field. And this field is going to continue to grow enormously. We're not going to talk about all the antiplatelet agents over here today. And we're only going to talk about selective anticoagulants. Obviously, heparin and warfarin cover the entire hemostatic schema. And we're going to focus on warfarin versus the 10A inhibitors, which we'll focus on. And we're not going to talk about the direct thrombin inhibitors. So what I'm going to talk about, I'm going to try to put today's management of anticoagulation in context in the history of anticoagulation development. We're then going to talk about our anticoagulation practices, which really has existed for the good part of the 40 plus years of my career, but now is an evolution. And then we're going to talk about the revolution of new anticoagulants that have really come into clinical practice in the last decade. And we're going to talk about the safety and efficacy of these agents in comparison to warfarin. And for general VTE and PE, and also in our cancer patients, since we are all hematologists and obviously have an interest in hematologic malignancy. And then, although you don't throw out the original baby with the bathwater, we certainly do have a role for warfarin, and these drugs, as of yet, the DOACs don't supplant it, but I think is overall a secondary anticoagulant for the complex case. So, you know, it started anticoagulation back in the 1930s when an internist by the name of Wright recognized that heparin can prolong the blood coagulation, and legend has it Irv gave him to himself for a pulmonary embolus. In the 1950s, it was recognized that warfarin, which was developed as a rodent killing agent, actually could safely anticoagulate individuals, and that could be management of thrombotic disease. And in the 1950s and 1960s, they actually used to treat patients with myocardial infarction with warfarin. although that fell out of favor in the 70s, but came back, of course. And these agents were the agents available up through the decades, not until in the United States, the mid to late 1990s, we had the injectable 10A inhibitors. And then finally, the first generation of oral anticoagulants, first with the direct thrombin inhibitor Dabigatran, and then very rapidly coming to use the direct 10A inhibitors. And likewise, in this period of time, we've developed reversals. But up until the current era, since DOACs have been available, we manage patients somewhat similarly for decades. And that is, when a patient presented with a serious venous thrombosis, usually behind the knee or above, and or a pulmonary embolus, we stabilized them with parenteral heparin, in the later years in the 90s switching to low molecular weight heparins. And then we transitioned these patients to warfarin over minimal 5 to 7 days, sometimes 2 weeks, and aiming for a stable INR of 2 and 3. And then we would anticoagulate 3 to 12 months, depending upon our concerns for the severity of the initial clot. And then the practice was to stop anticoagulation. And the reason for that is the oral anticoagulant was difficult in terms of management, which we'll come to, and the risk was relatively less to get a clot. We didn't really know those data till John Haidt's study in about 2000, where he showed that stopping anticoagulation gave us a recurrence rate of about 10% the first and second years, 3% from years 3 to 10, or an overall 30% likelihood of recurrence in the first 10 years. We accepted that in our practice. We said, well, there's a 30% chance, but there's a 70% chance you won't have a clot. So why take the warfarin and the risk of bleeding? And then if the patient had a second clot, we anticoagulated for life. Now the bleeding rate, it's hard to find good data, but it's about 2% per year. And that justified the use of warfarin in even our elderly patients for atrial fibrillation had a 4% stroke rate per year, even though the bleeding complications were high. So then in the last decade, work that started in the boardrooms of pharma companies in the developed world in the late 1980s and early 1990s, we had a host of oral anti-10As, and they're listed here: Rivaroxaban, Apixaban, Matrixaban, Edoxaban. And not listed as Dabigatran, the direct thrombin inhibitor. And they have made administration of these agents somewhat easier for the patient. Now, the pharmacology of these agents, the direct thrombin inhibitor, Dabigatran, has a very quick time to peak activity. In fact, all the oral anticoagulants do that, the maximum within 4 hours. That's distinctly different from warfarin, which not until you get 10A and prothrombin inhibition, minimal of 3 to 5 days, do you start to have adequate anticoagulation. Their half-lives were predictable. They had their own unique pharmacokinetics and pharmacodynamics, and essentially are 9 to 13 hours. Interestingly, Rivaroxaban is given once a day. Bauer took the risk of giving a higher dose based on the pharmacology because they didn't think people would want to take a drug twice a day. But the Eliquis people, on the other hand, followed the pharmacology, and there may be some salutary reasons for that. For the most part, these agents are metabolized in the liver, although the direct thrombin inhibitor is 80% excretion in the kidney, so you have to guard against renal failure in its use, and with the exception of 40% excreted, in the kidney. Now, if you compare the two sets of agents, warfarin requires dosing at least over 5 days, and that's, of course, in a healthy patient. obviously the majority of our patients, unfortunately, who need these agents aren't healthy. Their livers and maybe their kidneys aren't working as well, and oftentimes takes longer. It's mostly metabolized in the liver. And as you know, we monitored by the INR, which was an international standard that was developed in the early 1980s by Leon Polar, based on the Manchester standard of thromboplastin. The effect of warfarin is based on decreasing the level of the vitamin K dependent factors 2, 7, 9, and 10, as well as does decrease other vitamin K dependent factors, to levels of about 20% of normal, with the exception of factor 9, it's about 40% of normal. Optimal management with warfarin requires diet that limits leafy vegetables and the stability of diet. Things that you may have, for example, too much wine or some scotch may very well influence its metabolism, as well as antibiotics that you may get. Now, we do have an antidote, and this has been demonstrated with prothrombin concentrates in prospective randomized trials to be effective, and that's good. The cost is pennies, but in our country, although the drug may be inexpensive, the monitoring isn't. And unless you have adequate health insurance, you don't have access to proper monitoring. So that cost actually may be greater because the risks are greater. And the complications are bleeding. And then uniquely is the entity of warfarin skin necrosis. When you have an activated prothrombotic state, let's say in heparin-induced thrombocytopenia, or patient is already deficient from hereditary in protein C and protein S, and you markedly lower the levels because the half-life of protein C is much shorter than the half-life of factor 10 in prothrombin, and produce a hypercoagulable state, a very unique condition. If you compare the administration with a DOAC, as I've already shown, the peak time to action is within a couple of hours. The metabolism is mostly liver. You don't have to be monitored. Diet doesn't influence anything. You have its own pharmacokinetics and pharmacodynamics. It too has its antidotes. PCCs have been used, and there's a specific an inactivated 10A to sop it up, andexanet. That drug is being looked at in a prospective randomized clinical trial with PCCs as we speak. It does cost more, and its only complication is bleeding. Is the ease of administration sufficient to justify the use of DOACs over warfarin? Well, if you ask our patients, they'd probably say, of course. But what do we need to know to see if a DOAC would be a first choice versus the use of warfarin? Well, these data were published in the first major meta-analysis in Blood in 2014 that looked at these 7 phase 3 randomized prospective clinical trials that examined either Rivaroxaban or warfarin and looked at efficacy. And if you look here in these major trials, essentially on this forest plot, there's really not a significant difference in efficacy between a DOAC and warfarin in this mere meta-analysis that includes 27,000 patients for management of DVT and PE. It's an enormous amount of data. In fact, I'm not sure there's any other agents out in practice that have been studied with such enormous numbers of patients in prospective randomized clinical trials. This is the test to show the difference. And actually, there's been a recent meta-analysis looking at Rivaroxaban versus apixaban in efficacy, and it appears to be clinical, although there was a much smaller number of trials with good evidence to do this analysis. So they're equivalent in activity. So you could argue, well, if they're equivalent in activity and they're easy to take, isn't that justification alone? Well, let's go one step further. The major problem, of course, when we give an anticoagulant is bleeding. So we want the holy grail is to find an anticoagulant that prevents thrombosis but doesn't cause excess bleeding. So this is the same meta-analysis on the same 27,000 patients in the same clinical trials. And basically, there was no difference in recurrent VTE, which we demonstrated on the previous slide. And there wasn't any change in mortality between the oral 10A drug versus the vitamin K antagonist. But in all cases, with one exception, major bleeding, intracranial bleeding, fatal bleeding, and net clinical benefit, the DOACs had improved significance on the forest plot. Now, the exception is major GI bleeding. In fact, this has been not only in comparison with warfarin, but in comparison with low molecular weight heparin, the direct 10A oral anticoagulants have a higher risk. And this is probably a subgroup of patients who have the risk for GI bleeding, and we'll come to that in a few moments, that we probably want to avoid DOACs in. And in overall clinically recognized, not necessarily important bleeding, there was no difference between the two groups. So ease of administration, similar efficacy, but for the vast majority of our patients, reduced risk for bleeding really makes an argument that a DOAC we should reach first for. Now, what about cancer? Because all of us listening in this audience have an interest in cancer. So warfarin, suffice it to say, is the only drug anticoagulant that is proven to be ineffective in cancer. So this is a landmark study led by Agnes Lee. It was published in New England Journal of Medicine in 2003, where she showed where warfarin was compared with dalteparin, and clearly dalteparin was more efficacious in prevention of recurrent VTE. Although the bleeding between warfarin and dalteparin, whether all causes of bleeding or major bleeding, were the same. Small number of patients, however. In a retrospective analysis of the CLOT study, this was published in the Journal of Thrombosis and Thrombolysis in 2016, they extracted data. They had similar comparisons with dalteparin versus warfarin. Dalteparin was much stronger in reducing a venous thromboembolism, but in all bleeding or in major bleeding, there was no difference. So clearly in our cancer patients who have thrombosis, documented thrombosis, warfarin is the only proven agent to be ineffective in their management. What about DOACs? Well, this in the last year, it's been an exciting area because basically a lot of work has done, still small number of patients, to look at the role of DOACs in the management of 1, primary prevention, 2, treatment, and 3, secondary prevention of patients with cancer-related thrombosis. Now, this is based on risk profile analysis, Corona scores, and the variations. So we're not going to go into that today. That's really a topic for another time. But if you look at primary prevention of cancer-associated thrombosis in selected ambulatory patients, i.e. who had the risk profile to be higher risk, there's 2 prospective randomized trials, the Cassini and the AVERT trial, one with Rivaroxaban versus observation, and the second with apixaban versus observation. In both cases, the VTE rate was significantly less, but the bleeding rates between the groups were not different, justifying the use in selected patients who on risk stratification are high risk for thrombosis. For example, the pancreatic cancer patient was a good example. Now, in the management of DOAC-treated cancer-associated thrombosis, there's at least 3 trials, the first 3 trials. Still a total number of, not a large number of patients, less than 1,000 studied in prospective randomized phase 3 clinical trials. But in the edoxaban versus dalteparin, The VTE rate was not different, and the bleeding rate was not significant. In the Rivaroxaban versus Dolteparin, the bleeding rate was significantly reduced, and the VTE rate was significantly reduced, but the bleeding rate was not. And in the Apixaban versus Dolteparin trial, the smallest trial, it appeared that the VTE rate was dramatically reduced. I think the numbers are too small for us to strongly hang our hat on that, but the bleeding rate wasn't different. In secondary prophylaxis with DOACs, and this extends beyond the cancer patient, as I said, the risk of recurrence is 10% in the first 2 years, or 20% in 2 years, or the Beglin study, and in provoked situations, it's about 8%, provided it's not surgically. In the Amplify Extent trial, Apixaban was compared with placebo for reduction in thromboembolic events. And basically, regardless of what dose of Apixaban you use, there was a clear reduction in thromboembolic events with secondary prophylaxis, and not an increased risk in bleeding versus placebo. And likewise, Einstein Choice compared Rivaroxaban with aspirin. Compared Rivaroxaban versus aspirin, because aspirin had been proven as a secondary prevention agent in 2 randomized prospective trials within the last 10 years. And clearly, Rivaroxaban, regardless of the dose, further reduced the VTE rate without an increase in bleeding. In fact, one could say that for secondary prevention, after you've adequately treated your patient for thrombosis, the VTE rate, if you keep them on a DOAC, is between 1 to 2%. With aspirin, it's about 5 to 8%. So my conclusions are, for most patients, the DOAC is the agent of choice. But the kinds of patients I see aren't routine, and we do have a much smaller population, but not less significant. Clearly, warfarin is still the agent of choice for a patient with mechanical heart valves, and DOACs have been shown not to be successful. And clearly, for patients with antiphospholipid antibody syndrome, overall, no one has had a successful prospective randomized trial showing efficacy or equivalency of a DOAC. I do have concern on patients the small percentage of patients with venous thromboembolism that we see, who have protein C, protein S, and antithrombin deficiencies. I don't feel the data are sufficient to say that DOACs are adequate, and I've seen failures of patients with hereditary thrombophilia on DOACs. And likewise, in these situations that we're consulted for, patients who get recurrent thrombosis in a vascular access site, like for renal dialysis, patients with atrial or left ventricular thrombi due to cardiac disease, warfarin clinically, although there aren't randomized trials, appears to be effective agents, and I would be loath to eliminate its use and put a patient on a DOAC. And finally, unfortunately, in the United States, we do have a fair number of patients who don't have health insurance. Warfarin is financially available, although these patients unfortunately don't have the resources to be properly monitored, and each of us in our offices make an effort to provide them that care. So in conclusion, warfarin versus DOACs, I would go DOACs first for most patients, except for the caveats that I've mentioned already. Thank you very much for your time.
So thank you, Dr. Schmaier, for a nice review over there. We'll leave the questions for the end of the debate. And secondly, it gives me great honor to present Dr. Kenneth Bauer. He's a professor of medicine, Harvard Medical School at Beth Israel Deaconess Medical Center. He specializes in the evaluation and management of patients with thrombotic and hemostatic disorders. Dr. Bauer was a fellow in medical oncology and clinical research fellow in the division of thrombosis and hemostasis at Dana-Farber Cancer Institute, and was also a clinical research fellow in the hematology oncology division at Beth Israel Deaconess Medical Center. Dr. Bauer's major research interests include elucidation of mechanisms leading to the development of a hypercoagulable state, clinical evaluation of new antithrombotic drugs, and the molecular basis of factor VII deficiency. And he's going to make the case that warfarin is still there, is a major drug, and the podium for you, Dr. Bauer.
Well, thank you very much, and thanks for this opportunity. It's fun to discuss this with my colleague and friend Alvin. Let me jump right into it. Alvin's actually gone over much of this already. So let me have, let's see, next slide. So this is a debate. So we're supposed to answer the question yes or no. So I've looked up the definition of dead, and of course our current dictionary, of course, comes from the internet, dictionary.com, no longer current, relevant, or important. So it's a political year, and I know politicians like Alvin can't answer questions that are asked, but warfarin is not dead. While the use of warfarin, as well as low molecular weight heparin for new VTE, has been substantially reduced by the direct oral anticoagulants, it does remain an important option in our armamentarium of anticoagulation. Alvin's already reviewed advantages of DOACs versus warfarin. Of course, DOACs, their onset is very rapid. Their dosing is quite simple. It's pretty much fixed dosing, particularly for venous thromboembolism. We don't have food effects, which of course are an issue with vitamin K antagonists. We have very few drug interactions. We have no monitoring that's required, but at the same time, we really, while tests have been developed to measure levels, they're not widely available, nor do we really know how to use them based on outcome studies, even if we have them. And then they have a shorter offset of action too. So we can view a lot of these features of DOACs as real advantages, but I think you can also turn the table and say some of these advantages actually might be viewed as disadvantages. A short half-life without requirement for laboratory monitoring could lead to increased risk of recurrent thrombotic events, particularly if patients aren't adherent with drugs or discontinue drugs. But in all honesty, no anticoagulant works if you don't take it. DOACs are renally eliminated in part, variable extent. Alvin's already shown that. Warfarin is not. And many of our older patients do have some degree of renal impairment. Let's talk a little bit about assays, including point-of-care tests. They're not yet widely available to measure the plasma levels of DOACs where we practice in the US, even though assays have been developed and approved, I know, in other countries in Europe. Our regulatory agencies have not yet seen the value or seen the data that allows them to approve these assays commercially in the US, although many institutions have developed their own homebrew assays or use them without regulatory agent yet approval. Another issue then, of course, if you want to monitor, is concerned about medication adherence without monitoring, cannot titrate dose, and I'll come back to that. And I think most importantly, particularly without access to point-of-care assays, which would be highly desirable, you can't assess degree of coagulation inhibition if a patient has an on-treatment recurrence or in situations such as need for urgent surgery or setting life-threatening bleeding to know where you are in terms of how much drug is available. We do have reversal agents, as was spoken about, for now the DOACs. They weren't available when the drugs were introduced, but Andaxinet for the oral 10A inhibitors has limitations. I won't go into it in detail, but its use is not very straightforward, actually. It actually has a relatively short duration of action due to its rapid clearance, and it is very costly in the US, depending on whether you use a higher or lower dose regimen. It's anywhere from $25,000 to $50,000 for a single administration of Andaxanet. Alvin's already talked about high out-of-pocket medication costs may adversely affect adherence, a real-life problem. And then, of course, we have multiple agents with different schedules and doses. And arguably, while these drugs are still a lot simpler to dose than warfarin, I've seen a lot of errors being made in terms of their administration. So let me just comment quickly about the reversal issue. For warfarin 2, you have a tiered approach that's available to you if you do need to reverse. And of course, we have quite a robust laboratory tool to assess whether or not the degree of anticoagulation, of course, with the INR, and the maneuvers you can take depending on the severity of bleeding, of course, are just holding the drug if the INR is elevated and the patient is not bleeding, to administration of vitamin K. Intravenous is actually the most efficient, followed by oral. Sub-Q is actually the least. Giving fresh frozen plasma, or even in emergent situations where rapid reversal is required, giving a 4-factor PCC. So you do have a tiered approach for reversal. So now that DOACs are indeed an oral option, particularly for initial treatment, which again was the question, when should we consider not using them? During pregnancy, that's actually a hard stop for both warfarin and for the DOACs, at least certainly the DOACs because they do cross the placenta, and warfarin because of risk of teratogenicity, particularly between 6 and week 12. But DOACs actually should not be used postpartum if somebody has acute thrombosis, but warfarin can. There used to be mythology about warfarin getting to breast milk, but it's not true. And I just recently actually had a woman who had been on injections for many months of low molecular weight heparin, who needed an additional period of postpartum anticoagulation, and she was more than willing to go on warfarin to get away from the noxious injections of low molecular weight heparin. Situations in which people come in with massive pulmonary embolism, hemodynamically unstable, or very bad legs, phlegmasia, particularly where you're thinking of using advanced therapies like thrombolysis or mechanical thrombectomy, you're often going to be using heparin or low molecular weight heparin as a consideration, and sometimes perhaps even feel more comfortable switching them over to warfarin rather than a DOAC at that point. There remain questions about people at far extremes of body weight, since DOACs are dosed without regard to body weight, whether the morbidly obese, and I'm talking even way above 120 kilograms, or very small patients less than 50, whether indeed there are elevated risks at extremes of body weight. Renal dysfunction poses an issue. In fact, none of those studies Alvin included people with creatinine clearances less than 25 or 30. So we don't have a lot of data about using DOACs for initial VTE in people with renal impairment, even though some of the regulatory agencies have dropped the creatinine clearance to much lower levels for DOAC use, but without dose adjustment for venous thromboembolism. There are concerns about the many patients we see are obese or were obese and underwent gastric bypass, since the DOACs are largely absorbed in the upper GI tract, to make sure that the efficacy is preserved in those patients. And then finally, highly thrombosis-prone patients, people with recurrences on therapeutic anticoagulation, including some thrombophilias, which I'll speak to a little bit more. Alvin already mentioned APLS. And finally, the issue of adherence and cost are important issues. So I just showed this one example about the issue of body mass. It's a fairly dramatic example. It's not a patient with VTE, but it was reported quite a few years back now in the New England Journal, an individual on it for atrial fibrillation who they decided to switch from warfarin to dabigatran, and within 4 weeks after switching from warfarin to dabigatran, he had an ischemic hemispheric stroke, and you can see this patient was very obese with a body weight of 153 kilograms and a body mass index of 44.7. His creatinine clearance was normal. And what they did in this study was actually measure levels both when the patient first arrived, and then they continued to give dabigatran at the same dose for 3 days and monitor the drug levels in this particular patient. And what you can see happened, and you can see the wide therapeutic window of these drugs, the peaks in red, the troughs in terms of the intervals for 90% levels. You can see this particular patient at the trough essentially had essentially no dabigatran in their blood, and at the peak level was below the lowest level of the trough in the population study. So clearly a failure of therapy due to very drug levels in somebody who's morbidly obese. So let me turn then to antiphospholipid syndrome. Alvin already alluded to the fact that the DOACs have not performed well in people with thrombosis in antiphospholipid syndrome. It's obviously a complicated entity. It's an autoimmune disorder, which is defined by thrombosis. There also is obstetric APLS. It's arterial or venous, with one or more laboratory abnormalities that are persistently present over 12 weeks, either a lupus inhibitor, very high levels of beta-2 glycoprotein 1, or anticardiolipin, IgG or IgM antibodies. It's a very heterogeneous syndrome, if you will, with thrombosis in any vascular bed. They can have arterial or venous thrombosis, unlike the hereditary thrombophilias, which are almost entirely venous. And long-term anticoagulation with warfarin is the standard of care for thrombotic APS, particularly those who are so-called triple positive, with markers for all of those laboratory tests. But even with that, recurrent thrombosis remains common, maybe 10 to 20% on anticoagulation, 25 to 50%. And many years ago, 2 randomized trials actually showed that an INR of 2 to 3 was adequate, as effective as 3 to 4, at least as effective in venous thrombosis and APS. There were selected studies from rheumatology out of lupus clinics that suggested these people required higher INRs, but at least in venous thrombosis, 2 to 3 appears to be adequate. But what's occurred, of course, is the issue that in triple positive APLS, Rivaroxaban has not performed well in randomized trials. Now, these are long-term secondary prevention in very high-risk APS patients, triple positive people who were probably stabilized on warfarin and then either randomized to switching over to Rivaroxaban 20 milligrams versus staying on warfarin. And one of these studies in Italy was stopped after 120 patients due to a high event rate, 19%. The recurrent thrombosis was in 12%. They were all arterial events, and major bleed in 7% with Rivaroxaban versus 3% with warfarin. And another trial in Spain, very similar results. Recurrent thrombosis occurred in 11.6%. Very high risk of recurrence in those who are triple positive, 17.6%, 10 arterial, 2 venous, versus 6% in the triple positive on warfarin, 8.8%, 3 arterial, 3 venous. Most concerning is the stroke risk. 9 of the 11 recurrences in Riva were strokes versus 0 on warfarin. In non-triple positive patients, there were some in the Spanish trial. The thrombosis rates were lower, and clearly there's room for a lot more work in APS, and particularly in people who are not triple positive. But at this point, I think warfarin really is generally the standard of care. So let me conclude, warfarin is not dead and should remain alive as an anticoagulant option for initial VTE. I would propose that it's the only anticoagulant, including the heparins, that we truly know how to monitor. INR monitoring actually allows for personalized therapy. Your ability to up-titrate INRs over 3 in high-risk patients who've recurred on standard INR 2 to 3. Warfarin does take into account interactions with other drugs, body weight, and liver function. Believe it or not, there are some patients in my practice who prefer or like an anticoagulant that can be monitored through a simple blood test. And there are more patient-friendly approaches of reliable home INR monitors, and these people don't mind having blood tests. It is a low-cost generic medication, and importantly, the reason why warfarin is certainly not going away, even though it's not venous thrombosis, it remains the only anticoagulant option in patients with mechanical heart valve. So I thank you very much for the invitation and the opportunity to discuss this with you all.
Thank you, Dr. Bauer, and I think you did make an excellent case for warfarin, and you put all the indications. So there's really limited indication for DOAC here. So we'll jump to the Q&A sessions just to try to see how many questions we have there. And if the audience allows me, I'll start with one question. So for both of you, actually, those patients who have myeloproliferative neoplasia, whether essential thrombocythemia or polycythemia vera, sometimes prior to their diagnosis, they present with thrombosis. In these patients, would you prefer a DOAC or warfarin?
So some of it, there's another area I didn't get into, and that's thrombosis at unusual sites of portal mesenteric venous thrombosis. And of course, you bring up the myeloproliferative disorders, and indeed, splanchnic thrombosis is a very characteristic site of thrombosis in those patients. And you bring up a very important point, because obviously DOACs have not been studied well in portal venous thrombosis, but you know, at the same time, you know, I think you know, you could argue if you're extremely conservative in terms of you know, your therapeutics, we have a long experience with warfarin in these places of thrombosis of unusual sites, but you know, at the same time, and I'll help Alvin out a little bit here. You know, I think, you know, when you come to some of these indications, particularly venous thrombosis, you know, the data is very strong that anticoagulants of all types, with the exceptions, are overwhelmingly efficacious in treatment and prevention of venous thrombosis. So I have gone both ways in portal vein thrombosis, and particularly some of my long-term patients. I've had patients who, you know, just for one reason or another, are not willing to stay on warfarin, and many really don't like warfarin, and so forth. So I think DOACs can certainly be an option on an individualized patient. You get into one more larger question is, you know, if their myeloproliferative disease is poorly controlled when they develop thrombosis, whether that in itself is enough to basically treat their underlying hematopoietic issues or blood count elevations, along with an antiplatelet agent, which is standard with aspirin, whether an anticoagulant is required. But I dare say I generally do leave them on if they've had very severe thrombosis, particularly if it's unprovoked, even despite the fact you can argue that perhaps amelioration of their you know, problems with their blood counts might be sufficient. I'm pretty aggressive in trying to prevent recurrent thrombosis in those people with venous thrombosis using long-term anticoagulation.
So well, you raised a very complex area. So splanchnic vein thrombosis is very heterogeneous. Clearly, in the patient who has a myeloproliferative disorder is BAC2 positive, I'm concerned about portal vein and hepatic vein thrombosis. We see Budd-Chiari in these patients, and I would be reluctant to, I wouldn't put them on warfarin because we have major changes in liver function in that subgroup of patients. Those patients I usually manage with a parenteral agent. My drug of choice is fondaparinux, and which is well tolerated, provided the renal function is good. Now, in the patient who has a myeloproliferative disorder, JAK2, and has presented with leg thrombosis, CAF, and popliteal, relatively uncomplicated, we have used DOACs, and it's well tolerated. Obviously, we're concerned that the patients has been reliable in one, getting the phlebotomies if they had polycythemia vera, or two, are on adequate doses and using their doses of Hydrea to keep their platelet count below 600,000. Now I have a third, we have a third and a fourth population, the patient who presents with splanchnic vein thrombosis who has a hereditary thrombophilia, and this is particular protein C and protein S. I also manage them with parenteral anticoagulants, and my drug of choice, even though in the United States is very expensive, is fondaparinux. And the fourth group is patients with liver disease who present with portal vein thrombosis. I have a couple of hepatologists in my medical center who sends me these patients. And this is a very interesting group of patients because the portal vein thrombosis, it leads to splenic vein thrombosis, leads to esophageal and gastric varices, which leads to a lot of morbidity and rarely mortality in these patients. I actually, follow the guidelines that was first suggested to me by P.R. Minucci, that actually liver disease is a very prothrombotic state. And even though the APTT and the PT may be prolonged, if you measure the anticoagulants made in the liver, antithrombin, protein C, and some portion, but not completely, protein S, in patients with advanced liver disease, all of these anticoagulants are markedly low, and they are at higher risk for thrombosis at a different orbit or rheostat than bleeding. I've actually been managing these patients with low-level DOACs, with resolution of their portal vein thrombosis, if it's hasn't been there for a long time, and opening and maintaining patency. And we've not got into problems with bleeding if they don't have gastric varix. Esophageal varix has not been a problem. I think that's an area that's ripe for future investigation, clinical investigation. We see a lot, unfortunately, of liver disease, alcoholism, and actually the epidemic of people my age with hepatitis C and just developed liver disease, and basically, so that's an area where actually the DOAC has at lower doses has fit in quite well.
Okay, so there's a question from the audience. They're asking about what are the possible explanations that DOACs are less effective in mechanical valves. So I guess that would be for Dr. Schmaier.
Well, that's I'll try to answer that question. I don't really have an answer for that. It's not something I've really thought about extensively. I mean, the limitation of DOAC is you're going to you're working at the level of 10A, and you're not giving as broad of inhibition of 10As, the generation of 10A, and prothrombinase as you would with a more general anticoagulant, warfarin, that's hitting all of those coag factors and their ability to generate fibrin. Neither of the agents inhibit contact activation, although contact activation traditionally has not been a major feature in mechanical heart valves. It's really in the areas where there's low flow on or about the valve, where it's sewn in, or in the interstices of the more complex mechanical heart valves, that the clots occur. Contact activation could be, but none of the 10As really work there. So I think with warfarin, you're giving a broader level of just overall decreasing the risk, whereas the 10As aren't as, how should I say it, global in their inhibition of anticoagulation. Beyond that, I don't have any further insights. Ken?
Yeah, I think it's all, obviously we're speculating, but obviously warfarin works by a completely different mechanism. One of the other elements, of course, is when somebody is on, warfarin or a vitamin antagonist, the anticoagulation is constant and relatively steady, whereas with any of the DOACs, levels go up and down. They have peaks and troughs. So valves perhaps likely are a more prothrombotic milieu for thrombosis. We've known that obviously because the target INR for mechanical valves is more like 2.5 to 3.5, but nonetheless, the one study that did try to address this with Dabigatran did try to dose escalate the levels and monitor levels above the standard 150 milligrams twice a day to much higher levels. And even then, at those levels, they got into trouble, both with bleeding and thrombosis. I dare say, though, that the study really was extremely ambitious because they went into people immediately after valve placement in the post-op period, which was really came back to bite them because they had post-operative bleeds from giving very high doses shortly after heart surgery. But unfortunately, it's such a high-risk situation in terms of risk of stroke and risk of, valve occlusion that I don't think there's much appetite for any of major companies, nor many investigators to really study this in depth, unfortunately, at this point. Yeah, that's a great question. Can you hear me?
Yeah. So maybe Dr. Bauer, you can go first. So patients who are on secondary prophylaxis or on warfarin and they get a recurrent thrombosis, should they be switched to DOAC?
So we haven't seen a lot of data on this question, and one could also flip the question around. Or what do you do when somebody recurs on warfarin? Now, importantly, let's first start with the caveat that the patient was adherent, and that if they're on warfarin, that they were in range. Similarly, if they're on a DOAC, that they were adherent with taking the drug. And there are elements, particularly with Rivaroxaban, that it should, at the higher doses, particularly the therapeutic doses of 15 or 20 milligrams, be taken with food to maximize absorption. My practice, though, actually when somebody has an on-treatment recurrence, which happened in, about 2% of patients in all of those studies that Alvin showed, both with warfarin or DOAC, my preference actually is to probably give them low molecular weight heparin for a while to sort of cool them down. But then I would probably go back to warfarin or go to warfarin with the ability to monitor with high quality INR monitoring, sometimes initially, particularly if they've had a clinically very significant rethrombosis, either a recurrent PE or a major recurrence in their leg that's very symptomatic, even try to target a somewhat higher INR for 6 months, more like 2.5, just so they don't slip under 2. So I do have a preference actually for failures, and that includes warfarin failures too, to going low molecular weight heparin, or if you prefer fondaparinux for a while, and then going back to warfarin with higher levels. Something that I see people doing is then switching from one DOAC to another, but that's not my preference, and I try to avoid doing that unless my back is really up against a wall. I might say finally that I don't think this invalidates going back to a DOAC at some later point in their course once they've cooled down. rather than committing them, let's say, to long-term warfarin or long-term low-grade heparin. I think maybe you can circle back, and then I might be open to, maybe if one agent. But I think we just don't know is the answer, to be honest.
Dr. Schmaier, so would you consider adding aspirin to warfarin in those who recur?
Well, I wanted to echo Ken's statements, but I think when I see a patient who fails an anticoagulant, and we know that they're taking them and they have a good INR, let's say, I look for cancer as an underlying diagnosis. I retrace the steps to make sure that the patient doesn't have an antiphospholipid antibody. These patients are referred to me from the outside, so they're not initially my patients for the most part with this problem. But we do have a subset of patients, and I agree with Ken that when they fail either a DOAC or warfarin, my first choice would be to go to a parenteral agent, and I always go to Fonda because it's smaller volume. Excipients don't burn the patient as much, and it's only once a day versus twice a day. In addition to that subgroup, and I have people in that subgroup, then provided that compliance is good, we do consider one in Lovenox, not with Fondaparonox, but with Lovenox, increasing the dose by 20 to 25% as one approach if they fail. And then another approach is to add an antiplatelet agent. And we usually start with aspirin, but I do have patients who are on Fondaparonox, aspirin, and also are on a P2Y12 antagonist because they appear to fail as well. Although these are very complex patients. I'm thinking of one person in particular. She has P. vera and she has a JAK2 polymorphism, and so it's become a management. So I think you can add on an antiplatelet agent in the problematic patient on top of an anticoagulant, although generally I really try to avoid that.
So I guess we have like 3 minutes left, so I'll just throw in a last question. Cerebral venous sinus thrombosis, and which one would you choose, DOACs or warfarin in these patients? So Dr. Schmaier, you may go first.
Well, I consider that an extremely serious thrombosis, and I want my anticoagulation to be excellent. And so I probably, if they present with a cerebral sinus thrombosis, I would probably put them on a parenteral anticoagulant first, provided that I've not seen evidence of increased intracranial pressure and they have a risk to bleed. Once stabilized, would consider transferring them to a DOAC or warfarin, depending upon the patient, their ability for compliance. Those patients then substratify into individuals that have underlying risk factors, and if they do hereditary thrombophilia, then they're anticoagulated for life. But in patients who don't, then we would consider removing them at some time. This is an area that we really start to recognize enormously in the wide availability of MRI and the appropriate CNS imaging. Prior to the year 2000, when imaging wasn't so available, they were an extremely rare kind of patient to see.
Dr. Bauer, similar answer, or would you prefer?
Yeah, I think clearly we have options. I think in deciding among those options, I think, obviously you have to work with the patients and individualize both on the severity of thrombosis, how serious the clinical presentation in terms of symptomatic as well as clot burden. And then there's a discussion with the patient, what they're willing to accept and what they're going to be most compliant with. I agree. I have not, I've been a little hesitant perhaps to use DOACs out of the gate with cerebral venous thrombosis, but I have had a number of people on long-term therapy who've been switched over to them. Then there's a question as what's the natural history of cerebral venous thrombosis? Do the same principles apply that were put forth for unprovoked, if you will, DVT and PE? A lot of cerebral sinus thrombosis in young women is oral contraceptive related, arguably provoked event with a relatively low recurrence rate. So there's a lot of room for I think individualized therapy. There is literature, but it's not nearly as robust as the DVT or the pulmonary embolism literature on recurrence risk and so forth. But I think these things could be individualized. But I am more cautious in that population, as Alvin is as well.
Okay, thank you for both of you for your kind time tonight. Wonderful talks from both of you. I learned a lot, and I hope the audience learned a lot, and hope to see you in the near future. Thank you very much. And
thank you. Ken, take care. We'll see you soon. Best
take care.
regards.
Thank you very much. And
Enjoy
for
the opportunity.
Thank you very much. And for the audiences, I just like to remind you that we will be having next week our weekly seminars, and it will be about multiple myeloma, where Dr. Philippe Moreau from France will be discussing about how he treats newly diagnosed multiple myeloma, followed by Dr. Ayman Hijazi, who will be shedding some insights on treating relapsed refractory multiple myeloma. So hope to see all of you next week. Thank you very much, and have a good night.